I use the same system that we've used in the presentation, which is the NIH consensus grading system, updated in 2014. And actually, this was actually the first structured effort to better define what constituted chronic GVHD from a clinical perspective, and also try to make sense of the scoring or stratification of severity. This is as the title says, moderately severe case of chronic graft-versus-host disease. The scoring in general, because it's a complex scoring system, just like the disease. The scoring is based on basically two things. One is the severity of involvement of the organs in question. And the second one is the number of organs involved. And that is how we get to an overall grade that defines whether the patient is in the mild, the moderate, or the severe category. In general, the way we approach these different categories is that mild categories are handled without systemic therapy if possible, which is what happened in the case of this lady. And then once we move into the severe level, moderately severe or severe level, both, we offer systemic therapy. Ideally, that systemic therapy would be within a clinical trial, and in the absence of a clinical trial is prednisone at a dose of 1 milligram per kilogram per day.
Usama, do you do prednisone at a mg per kg, and do you give a calcineurin inhibitor with the prednisone when you start systemic therapy?
So that's an excellent question. I do use 1 milligram per kilogram per day. Yes, I do think, and this is largely empirical, that all GVHD is a very time-dependent disease. So, as time goes by, I think that you lose ground. So I try to be aggressive upfront, and I do use the mg per kilo. I would tell you always, when I decide to treat, I treat. And as far as the calcineurin inhibitor, I do use it as well, because although it has not been proven to increase the efficacy of the steroids, it has shown steroid sparing capacity and less long-term steroid-related complications. So, which, as we all know, become a huge problem over time. Blends into, the syndrome of chronic GVHD. So I do use them as well.
Sama, what about you?
I do more or less the same, the 1 mg per kg, but with a fast taper. I'm a fan of ECP for chronic GVHD. So I jump into ECP earlier. Depending on the timing, if my patient does not respond fully, and obviously steroids are very toxic, I can add other agents. If it's earlier on, let's say the first 6 months or so, most of our patients will be already on calcineurin inhibitors, so you have not even stopped it. A year and a half, it will be a case by case.
What are your thoughts on the CTN study that looked at sirolimus with a tacrolimus sort of withdrawal approach to foster regulatory T cells? Is that something either of you have adopted into your practice? I'm talking about CTN 0801.
I have not. I use sirolimus sparingly. So again, culturally, in my practice, whether in New York or here, I have not adopted this as an algorithm.
I haven't adopted it either yet, because it is a big change in practice. Big change in practice, and I'm not saying that that it's not a great. The idea behind this CTN study is not great, but I think that the size or the magnitude of the change in practice is directly proportional to how much data you need to see on that particular topic. I think that I need to see more to change my practice to using sirolimus that way.
So let me ask you, Dan, your patient now is 2 months on corticosteroids at a healthy dose at 1 milligram per kilo, and the scleroderma is not better. In fact, perhaps it's even worse. What do you reach for next?
So so 2 months is probably a little more than I would wait, but let's go with the 2 months. And so at this point, I would definitely go to to an additional agent. And as we all do and know, we actually look at two things in these agents. One is efficacy, and the second one, of course, is the steroid sparing capacity. So the first thing I look at is, do I have a clinical trial? Because our standard therapies are, of course, less than optimal. And if I don't have a clinical trial, my go-to treatment would be ECP, extracorporeal photopheresis, which does have a track record, good track record in the treatment of sclerodermatous forms of chronic GVHD.
Usama, what about you?
I would have gone to ECP earlier than the 2 months. So 1 mg per kg for 2 months is a very, very long time. The cumulative dose of it's a huge cumulative dose on. I forgot how old this man is. Well, luckily he's younger. He's 35. So I would have gone into ECP much earlier. Ibrutinib is a drug that we can use. Obviously, clinical trials are is the first choice. It's becoming a cliche now after we say that too many times. It should be where we go first.